Today we will discuss about the aminoglycoside antibiotics. So within the antibiotics, one of the important group of antimicrobial agents is the aminoglycosides. Now these aminoglycosides are basically active against the gram-negative organism, particularly aerobic gram-negative organisms. So when the penicillin was invented and different other antibiotics are continuously coming to the market, then appropriate search is started to target the gram-negative organisms like different types of the Enterobacteriaceae, different types of the E. coli, Klebsiella, Proteus, Pseudomonas, that ultimately causes different types of the infections that can be life-threatening. Different that can be respiratory tract infection, urinary tract infection, skin and soft tissue infections, etc., etc. So due to this active search, first the streptomycin was discovered, and this streptomycin was discovered from Streptomyces griseus, which is a bacteria. So from different types of the natural bacteria, these different antibiotics are discovered, and then different congeners are discovered. Mainly this after the streptomycin previously used in different gram-negative organisms, but it has been seen that if we use it continuously, the resistance are going to develop. That's why now this streptomycin is only used in case of the tuberculosis. In case of the Mycobacterium tuberculi, it is active. And after the streptomycin, griseofulvin and different other aminoglycosides are also discovered. These aminoglycosides are mainly obtained either from the Streptomyces species, different types of the Streptomyces species, or Micromonospora species. And according to whether it obtained from the Streptomyces species or Micromonospora species, there is slight difference in the spelling of the names of these drugs. We will come to this, whether it is MYCIN or MICIN. This ultimately difference mainly happens due to its source, whether it is obtained from the Streptomyces species or Micromonospora species. Now these aminoglycoside antibiotics are mainly bactericidal. So previously we have seen that and it also acts on it inhibits protein synthesis. So different other antibiotics are also there that inhibits protein synthesis. You have already read about the tetracycline, chloramphenicol, which are the broad spectrum antibiotics. You have already read about the macrolides. But most of these drugs are bacteriostatic, that is they decrease or ultimately halts the multiplication of the bacteria. But this aminoglycosides is basically bactericidal, that is it kills the bacteria. So these aminoglycosides mainly acts by inhibiting the protein synthesis mechanism of the bacteria by action on the 30S ribosomal subunits mostly. But some aminoglycosides also act on the 50S ribosomal subunit and the 30S 50S interface. This is the first one. Next is these aminoglycosides are mainly water soluble. They are not lipophilic and they are very less absorbed if we give this by means of the oral route in the gastric juice. That's why we have to administer these aminoglycosides in most of the cases either intramuscularly or intravenously. And there are some ointment or cream form is also available for the aminoglycosides. Next is aminoglycosides are toxic also. So main toxicity of the aminoglycosides that you have to remember are the two. One is the ototoxicity and that is the nephrotoxicity. Ototoxicity means it has some adverse drug reactions on the ear and different inner ear structures. That is, it ultimately deteriorates both the hearing capability as well as the vestibular apparatus that mainly maintains the balance. That is, our inner ear mainly controls, one is the hearing and another is the balance. Both of these can be compromised if we use the aminoglycosides. Next is, it is also very much nephrotoxic. That is, it mainly deteriorates and it also acts on the renal cortices and proximal tubules and destroys these. So that's why aminoglycosides, we have to use this judiciously, and if we use it multiple times and if we use it multiple times in a high amount, these types of the adverse drug reactions, the propensity will be more. That's why the recent guideline says that we should use it once daily dose but in a somewhat higher dose so that sometime it will be aminoglycosides free in our cortical fluid as well as in the nephrons. This is because these aminoglycosides particularly show some concentration dependent killing. That is, if this aminoglycosides concentration is somewhat higher than a range, it ultimately kills the bacteria. So, if we are giving some aminoglycosides in high dose, but the frequency is less, because these aminoglycosides half life is very less, 2 to 4 hours. So, we have to give this multiple times, but this multiple times dosing increases the likelihood of different types of the adverse drug reactions. That is why we have to use these aminoglycosides usually now once daily dosing, but in a high dose. That ultimately gives rise to the high concentration, and there will be some post-antibiotic effect also. That is, even after this aminoglycoside concentration is below the therapeutic range, that ultimately kills the bacteria due to some post-antibiotic effect. It happens due to the change in the modifications of the 30S and 50S ribosomal subunit. Okay. And this aminoglycoside is also an example of low therapeutic index. So, you have read about the therapeutic index. This is an example of the low therapeutic index drug. That is why if there is somewhat high concentration, there will be more chances of the adverse effects, and somewhat lower concentration effect will not happen. That is why therapeutic drug monitoring can also be done for these aminoglycoside antibiotics. Usually trow levels are usually checked to see whether what is the plasma concentration of the aminoglycosides. So, I have given about nutshell about the aminoglycosides. So, this is the structure of the aminoglycosides. So, this is a polybasic amino group linked glycosidically to 2 or more amino sugars. So, these are the different amino sugars and glycosidic linkages are there. So, this is the classification. Usually we use systemic aminoglycosides, example Streptomycin, this is the first one, already I have said. Then Gentamicin, Kanamycin, Amikacin, Sisomycin, Tobramycin, Netlimycin. So, Gentamicin, okay. So, after the Streptomycin, next comes the Gentamicin, and these are the different other drugs, and there are some topical agents also like Neomycin and Framycin. So, aminoglycosides, how it was discovered, I have already said. The Streptomycin was first discovered by Waxman in 1944 from the Streptomyces griseus. Neomycin was just isolated in 1949, and then the other drugs like Gentamicin have also come. Now, this Gentamicin and Netlimycin, it was mainly obtained from the Micromonospora. So, they are coming the difference in the spelling. So, this mainly comes from the Micromonospora species, that is why MICIN. And which aminoglycoside antibiotics? They come from the Streptomyces species or other types of the species. These are the MYCIN. Okay. So, you can see Streptomyces species, the suffix is the MYCIN, and Micromonospora species, if it is the source, the suffix is the MICIN. So, you have to keep you have to know about the spelling. So, there are some difference in the spelling. So, it has often asked in the Viva also about the spelling. So, Streptomyces species, we can obtain the Streptomycin, Paromomycin, Neomycin, Tobramycin, MYCIN. And from the Micromonospora species, we can obtain Gentamicin, Amikacin, Netlimycin. These are the MICIN. So, it is clear, just difference in the source from which it is obtained. So, these are again, what are the sources? Like Streptomycin is obtained from the Streptomyces griseus, Neomycin is obtained from the Streptomyces fridei, Kanamycin is obtained from the Streptomyces Kanamylelicticus, Gentamicin, the spelling is, it is wrong, Micromonospora, Netlimycin, Micromonospora, Tobramycin from the Tenebrarius, Dicarius, etc., etc. So, details is not required, just remember what is the source of these antimicrobial agents. So, this I have discovered. So, there are some common properties of the aminoglycoside. This is often asked in the examination also. So, what are some common properties of the aminoglycoside? The first one are, these all are the sulfate salts which are highly soluble in water. So, these are not lipophilic, these are hydrophilic. That is why it is less absorbed if there is cell membrane is there. They ionize in solution, not absorbed orally, distribute only extracellularly. Usually, its volume of distribution is equivalent to the our own extracellular fluid, and it do not penetrate to brain and CSF. All are excreted unchanged in urine. All are bactericidal and more active at alkaline pH. So, if it is alkaline pH, the aminoglycosides are more active. They act by interfering bacterial protein synthesis. Remember, they are active mainly against the aerobic gram-negative bacteria. But the different types of the aminoglycosides also show some broad spectrum. They are some active against some gram-positive organisms also. they have shown some partial cross resistance. So organisms resistant to one type of the aminoglycosides may be resistant to another type or maybe respond to the another type. Narrow margin of the safety, and all exhibit ototoxicity and nephrotoxicity, what I am discovered. So these are the common properties already we have discovered. Now coming to the mechanisms of the actions. So the aminoglycosides, the first one is it is a bactericidal antimicrobial agents, and this bactericidal effect usually shown when this aminoglycoside concentration is higher than its one range. Now when this aminoglycoside is given by parenteral route, it ultimately transported through the bacterial cell wall and cytoplasmic membrane depending upon polarity and oxygen dependent active process. So oxygen dependent active process is necessary for these aminoglycoside antibiotics to enter within the bacterial cell. That's why anaerobic organisms are usually resistant to aminoglycosides. So anaerobic organisms cannot be killed by aminoglycosides because oxygen is needed. Oxygen dependent transport process is needed for entering within the cells. Now it binds to the ribosome, resulting in inhibition of the protein synthesis. Mainly the Streptomycin mainly binds with the 30S ribosome, and there are some other aminoglycosides that also binds with the 50S ribosome or 30S 50S ribosomal subunit interface. So ultimately after binding, they distort the messenger RNA translocation of the genetic code. So this is the step in the translation. So how the protein synthesis happens in the bacteria, this protein synthesis is inhibited. So ultimately it prevents the formation of the normal complex required to initiate the protein synthesis. Now different aminoglycosides cause misreading at different levels depending on their selective affinity. So there are different affinity towards this 30S or 50S ribosomal subunit, and accordingly they inhibit at different levels. They causes the misreading of the code, they inhibit, they freezes the initiation complex like this. They also combines the anionic membrane group and damage the bacterial cell membrane, like proteins, amino acids leak out, and they also block the energy production of the Krebs cycle. So you can see, so this is the aminoglycoside is the red one, the red spot is the aminoglycoside. This is the normal protein synthesis translation in the bacterial cell. So this is the growing polypeptide chain, 30S and 50S ribosomal subunits. This green one is the 30S, purple one is the 50S ribosomal subunits. So when these red ones, that is the aminoglycoside attaches with this mRNA complex that is present on the 30S or 30S 50S interface, first that blocks or freezes the initiation of the protein synthesis. The protein synthesis will not be initiated, one point. Next is, even if it initiates, blocks further translation and elicits premature termination. So further translation happens due to the attachment of the different other polypeptides one by one. The attachment of the polypeptides ultimately blocks and premature termination of the polypeptide chain happens, so that the protein will be defective, the bacteria will not survive, or it can incorporate incorrect amino acid. This happens by means of the misreading of the mRNA code. So due to the misreading of the mRNA code, again defective protein will be synthesized and the bacteria will not survive. So this is the three ways by which site changes the genetic code in the mRNA, and ultimately the translation is blocked. The same thing, so aminoglycosides penetrate the cell membrane through aqueous pores, and then it reach the periplasmic space. Then it is taken up by active transport into the cell, bacterial cell, and this active transport needs oxygen. That's why the anaerobic organisms are resistant to aminoglycosides. Only gram-negative aerobic organisms are basically sensitive to the aminoglycoside antibiotic, remember. Then it binds most commonly 30S ribosome, but remember some also binds 50S or 30S 50S interface. And then ultimately there will be three types of the mechanism. Either it blocks or freezes the initiation complex, or it terminates protein synthesis or addition of the incorrect amino acid by misreading of the genetic code. So ultimately protein synthesis is inhibited, and lastly the bacteria will be killed, that is the bactericidal action happens. So it is clear about the mechanism of action of the aminoglycosides. Now what I am in the starting telling about the post-antibiotic effect. So aminoglycosides, first it shows concentration dependent killing, that is increased concentration can kill more bacteria at rapid rate. So if we are using very high dose just once in a day, that ultimately reaches very high concentration and kills most of the bacteria. But the half-life is the short. So there will be some time when the aminoglycoside concentration is below the therapeutic range. Even if they possess significant post-antibiotic effect, because they continue to suppress bacterial growth several hours after fall in minimum inhibitory concentration. So single daily dosing at least as effective as and no more toxic than multiple dosing. So previously multiple dosing, usually 3 times daily dosing of the aminoglycoside is given because the half-life of the aminoglycoside is less, 2 to 4 hours. But it has been seen that if we are using these aminoglycosides in multiple daily dosing, that ultimately causes more nephrotoxicity, more ototoxicity. That's why different clinical trials are done. It has been shown that if we are using high concentration once daily, that ultimately causes less adverse drug reactions, but the efficacy is also very good. So high dose extended interval administration of the aminoglycoside is the preferred means of administering aminoglycoside for the most indications and patient population. So this is the recent theory, and now we are using like this. So now coming to the antimicrobial spectrum. So mainly they are targeting aerobic gram-negative bacteria. Aerobic gram-negative bacteria are mainly targeted by the aminoglycoside antibiotics. So Cytobacter, Enterobacter, E. coli, Klebsiella, Shigella, Protea, Pseudomonas, as well as there are some gram-positive organisms like Enterococci or Staph aureus can also be sensitive to the aminoglycoside antibiotics. Streptomycin and kanamycin, it has been shown to be active against the Mycobacterium tuberculosis, while amikacin, gentamicin and tobramycin are active against the Streptococcus faecalis and Pseudomonas aeruginosa, because there are very less drugs that are active against the Mycobacterium tuberculosis, anti-tubercular drugs, as well as there are very less drugs that are active against the Pseudomonas aeruginosa, that also causes some fulminant infections. It is not effective against the gram-positive bacilli, gram-negative cocci and anaerobes, remember, okay. So these are the gram-positive cocci. So you can see these are mainly active against the gram-negative bacteria, different types of the gram-negative bacteria, as well as some gram-positive cocci. But it is not active against the gram-positive bacilli. It is not active against the gram-negative cocci as well as the anaerobes. Already we have discussed about the anaerobes. So aminoglycosides are not effective against anaerobes, already we have discussed, because they need to enter within the bacterial cells, and that needs oxygen to enter within the porine cells, because this is an oxygen dependent active process. Okay. So facultative anaerobes are also resistant in oxygen supply deficient. Facultative anaerobes means there are some bacteria that may survive without oxygen, but mostly they need oxygen. So in those cases, if there is no oxygen, again so oxygen deficient areas, what can be? Example, within the abscess. So when there is some abscess like liver abscess, within the abscess there will be closed container like structure, so that there will be less oxygen. So in those cases, even if we are using the aminoglycoside antibiotic, that cannot enter within the cells that have been affected by the bacteria, so they cannot act. Okay. Resistance, that is the very problematic. So it has been discovered first in the 1944. Previously it was used much, newer and newer drugs also came, but then it has been shown that most of these have become resistant. Again now it has been resurgent because there are different types of the fulminant infections, mainly the different enterobacterial species like Pseudomonas, Shigella, and we are using these aminoglycosides mainly in combination with the other antibiotics. So ultimately this resistance may develop due to the failure of the drug penetration, because these porine channels may be mutated if we are using this for a long period of time, so that there will be decrease in aminoglycoside transport mechanism. The synthesis of the metabolizing enzymes like acetyl transferase, phosphotransferase, adenyl transferase, this can happen. So ultimately that can lead to the acetylation, phosphorylation and adenylation, so the antimicrobial agent cannot act. Mutation may alter the ribosomal binding protein, so there will be change in the binding protein, so it cannot bind, and cross resistance is also observed. So absorption, already we have seen, it is not absorbed orally, mostly we have to give parenteral route, intravenous or intramuscular, plasma peak concentration 30 to 60 minutes, Distribution mainly the extracellularly 20 to 30%, high concentration in endolymph and renal cortex. Endolymphatic fluid within the inner ear as well as the renal cortex, it achieves high concentration. That's why the adverse effects are ototoxicity as well as the nephrotoxicity. It do not cross the blood-brain barrier, may cross placenta, they get distributed in serous fluids like synovial, pleural, peritoneal, etc. Excreted unchanged in urine. After chronic dosing 2 to 3 weeks, the drug persists in urine, and in elderly people and neonates, the drug dosing should be low as they have low glomerular filtration rate. In the elderly, already the glomerular filtration rate will be less, so that there will be more nephrotoxic potential. Renal clearance of the aminoglycoside parallels creatinine. So, by measuring the creatinine clearance, we can see what is the clearance of the aminoglycosides. So, now coming to the toxicities, already we have started discussing about this. These are very important. First is the ototoxicity. Now, this ototoxicity is the most important dose and duration of treatment related adverse effect. That is both dose as well as the duration. That is how much time, how many days we are using the aminoglycoside as well as in what amount. The vestibular and cochlear part both may be primarily affected by the particular aminoglycosides. These drugs are concentrated in the labyrinthine fluid and are slowly removed from it when the plasma concentration falls. The vestibular and cochlear sensory cells and hairs undergo concentration dependent destructive changes. So, concentration dependent destructive changes of the hair cells happen. So, cochlear damage mainly starts from the base and spreads to the apex. That's why the high frequency sound hearing loss mainly develops first, and then the low frequency sound hearing loss happens. So, ultimately same thing, hearing loss affects the high frequency sounds first, then progressively encompass the lower frequencies. মানে পেশেন্ট বলছে যে জোরে কথা বললে শুনতে পাচ্ছে না, খুব আস্তে আস্তে কথা বললে কিন্তু প্রথমে থেকে শুনতে পাচ্ছে। ওকে, বিকজ দিস হেয়ার সেলস ফার্স্ট ডিস্ট্রয় হচ্ছে বেস থেকে। বেসটা তোরা আগের জন্য অ্যানাটমিটা পড়িস, বেস মেইনলি হাই ফ্রিকোয়েন্সি সাউন্ডস হিয়ারিং এর ক্ষেত্রে কাজ করে, এন্ড দিস হেয়ার সেলস দ্য অ্যাপেক্স মেইনলি লো ফ্রিকোয়েন্সি সাউন্ডস হিয়ারিং এর ক্ষেত্রে কাজ করে। ভেস্টিবুলার ড্যামেজ হয়, ভেস্টিবুলার ড্যামেজ দ্য পেশেন্ট মেইনলি কমপ্লেন্স অফ হেডেক, নাউজিয়া, ভমিটিং, ডিজিনেস, নিস্টাগমাস, ভার্টাইগো, অ্যাটাক্সিয়া, মাথা ঘুরছে, এগুলো খুব কমন। If we are using aminoglycosides, because if there is some fulminant, for example pneumonia, severe pneumonia, we have to use the aminoglycosides. The patient is admitted in the ICU and different other drugs. Now after the recovery, the patient may complain that there will be some headache, there may be some nystagmus, some nauseating tendency. All this happens due to the action on the vestibular apparatus within the inner ear. So both of these can be damaged. Now what happens, this ototoxicity, even if we are stopping the drug, this ototoxicity persists for a long period of time, and sometimes 1 to 2 years even after we are stopping the drug, and in many cases complete recovery will not be possible if the patient have to take the aminoglycosides in high concentration for a long period of time, for example some weeks or some months. So many of the patients will suffer hearing loss for the rest of his or her life. That may happen. Now coming to the nephrotoxicity, tubular damage, mainly again the concentrating mechanisms of this aminoglycoside concentrate within the cortical cells as well as the proximal tubule. So aminoglycosides attain high concentration in these areas, and it is more so in case of the elderly and those with pre-existing kidney disease. So in those cases, if we are using this, that leads to low GFR, glomerular filtration rate gradually diminishes, nitrogen retention happens, albuminuria happens, and different renal cast can also develop. But this nephrotoxicity is usually reversible. So when we are stopping this drug, in some weeks, usually the GFR returns more or less towards the normal level. So ototoxicity is usually not reversible, but nephrotoxicity is reversible. Neuromuscular blockade is the third adverse effect. All aminoglycosides basically reduce the acetylcholine release from the motor nerve ending. So you know, this is the acetylcholine is the main neurotransmitter in the motor nerve endings. So they reduce the release of this neurotransmitter. So ultimately they have some urea like action. So we have read in the skeletal muscle relaxation chapter about the urea like actions. So ultimately they show similar type of action. So this mainly cause the neuromuscular blockade. So when the neuromuscular blockade happens, so there may be some propensity of the paralysis, and if there is paralysis of the respiratory muscles, that may lead to respiratory arrest also. So mainly we are using the skeletal muscle relaxants to smoothen the respiratory muscles and different other muscles so that the surgery will be easier. So they ultimately causes similar type of the effects, neuromuscular blockade, so that there may be some problems. They may cause apnea on intravenous injections. The blockade, if severe, can be effectively treated by neostigmine. In the same area, if we want to reverse this neuromuscular blockade, we have to use this neostigmine. Here is also, if there is some toxicity, we have to use the neostigmine. So some precautions and interactions when we are using the aminoglycosides, we should avoid during pregnancy because there will be risks of fetal ototoxicity. So fetal ototoxicity may happen, that's why we should not use in the pregnancy. Avoid concurrent use of other ototoxic drugs. Example, high ceiling diuretics, furosemide. Furosemide is also ototoxic drug. So we should not use minocycline, is also ototoxic drug. Avoid concurrent use of other nephrotoxic drugs like amphotericin B, antifungal agent, vancomycin, cephalosporin, cyclosporin is an immunomodulatory agent. These ultimately have nephrotoxic potential. Again, we have to be cautious when we are using these drugs. Cautious use in patients post middle age and those with kidney damage. So we have to check whether what is the creatinine level, and then we have to prescribe this. Cautious use with muscle relaxants. Already we have discussed because already it has neuromuscular blockade like actions. Do not mix aminoglycosides with any drug in same syringe or infusion bottle because there may be very much interaction with other drugs. Now the dosing regimen, because of the low safety margin, it is a low therapeutic index, low safety margin, aminoglycosides, all of the aminoglycosides. That's why we have to calculate the dose. For an average adult, usually for the gentamicin, tobramycin, sisomycin or netlimycin, 3 to 5 mg per kg per day, and for streptomycin, kanamycin and amikacin, 7.5 to 15 mg per kg per day. So this is more or less average dosing that is needed. Now already we have discussed about the short T-half, but even if we need approximately 3 times daily dosing, it leads to more adverse effect. That's why we are using high dose but once daily dosing. Okay. So this is the graph. You can see. So ultimately most authorities now recommend a single total daily dose regimen for patients with normal renal function. So the green one, you can see above the green one there will be toxicity. So when we are using very high dose, so ultimately that kills most of the bacteria, but in most times of the day it will be less than in the toxicity level, less than the toxicity threshold. But when we have to use it multiple dosing, there will be, you can see, in most of the times in the day it will be above the threshold of the toxicity level. So this is the dose response curve, time and the plasma concentration curve, by which you can clearly see that if we are using once daily dosing, even if the half-life is very less, that ultimately leads to more killing of the bacteria and less adverse effects. And this is ultimately possible due to its post-antibiotic effect and concentration dependent killing, these two things. Okay. Now coming to the streptomycin. Streptomycin is the first one that was discovered. This is obtained from the Streptomyces griseus. Particularly now it is used now mainly for the treatment of the tuberculosis. And it is also active against the Haemophilus ductei, Brucella, Yersinia pestis, tularensis, Nocardia, Klebsiella, E. coli, Enterococcus, etc. But most of these organisms have shown resistance. That's why mainly used in case of the tuberculosis. And there may be some streptomycin dependence also. So certain mutants become dependent of the streptomycin as they promote mutant growth. So this occurs when the antibiotic induced misreading of the genetic code becomes a normal feature for the organism. Mainly it happens in the tuberculosis. So you know there are multi-drug resistant tuberculosis is also on the rise. So there are different drugs that also shows the resistance, and this is one of the mechanism of resistance against the streptomycin. So the organism becomes dependent and ultimately they change their protein likewise so that the organism ultimately survives even if the streptomycin is given. Okay. So now it is mainly used in tuberculosis or some rare or uncommon infections like tularemia, subacute bacterial endocarditis, plague, etc. So pharmacokinetics is more or less similar and adverse effects is also more or less similar. So this is basically the prototype drug of the aminoglycosides. Already we have discussed about this. Gentamicin is the prototype which is obtained from the Micromonospora species. That's why MICIN. This was prepared in discovered in the 1964. Plasma applied, same thing. More potent, broad spectrum of activity, effective against Pseudomonas aeruginosa and most strains of the Proteus, E. coli, Klebsiella, Enterobacter, Serratia. So ultimately, these types of the gram-negative organisms now at present gives rise to different types of the fulminant, life-threatening infections. Many Pseudomonas aeruginosa or Shigella organisms are resistant to other types of the antibiotics that we commonly use that have less adverse effect. In those cases, we have to use the aminoglycosides. But it is not effective against the Mycobacterium tuberculosis, Streptomyces, Staph aureus, etc. and it is more nephrotoxic. Gentamicin mainly used restricted to serious gram-negative bacillary infections. What I am telling, serious infections, now we are mainly use the gentamicin. Like it is very valuable for preventing and treating respiratory infections in critically ill patients. That is, the patient is already in the ventilator or patient is already in the intensive care unit, as well as the patients have some impaired host defense, that is some immunocompromised disease is present, like the patient is already receiving some anti-cancer drugs, or the patient is on high dose corticosteroids, or the patients have HIV AIDS, or there is neutropenia. If there is neutropenia, there will be less host resistance to the normal attack from the different other pathogens. So, patient in resuscitation wards with tracheostomy or respirators or ventilators, post-operative pneumonia, patients with implants and in ICUs. So, remember, in those cases, in these serious cases, we have to use the gentamicin. And also the different other antibiotics are also given in concordance. Septicemia, sepsis, fever in immunocompromised persons, subacute bacterial endocarditis, different types of the Pseudomonas, Proteus and Klebsiella infections, particularly in burns, urinary tract infection, pneumonia, lung abscess, osteomyelitis, middle ear infections, meningitis by some gram-negative bacilli. In those cases, and topically can be used in some infected burns, skin lesions and purulent exudates, etc. So, from this you can see different types of the fulminant, serious infections, be it in the lungs, be it in the different other areas like septicemia, we can use the gentamicin. Kanamycin is obtained from the Streptomycin, Kanamyceticus, more or less similar to the Streptomycin. It is also active against the Mycobacterium tuberculosis, but it is not active against the Pseudomonas aeruginosa. More toxic to the cochlea and kidney, mainly it is used in the treatment of the multi-drug resistant tuberculosis. Now, kanamycin is used as a part of the regime for the treatment of the multi-drug resistant tuberculosis. Tobramycin, it is identical to gentamicin, obtained from the Streptomyces tenebrarius, used in mainly different types of the Pseudomonas and Proteus infections, and ototoxicity and nephrotoxicity is somewhat lower. Amikacin is a somewhat newer ones whose adverse effect is somewhat also lesser. It is a less toxic semi-synthetic derivative of the kanamycin, but more hearing loss happens. Usually you can see in the words that amikacin is used in various gram-negative infections, but again ototoxicity chance is more. It is resistant to enzymes that inactivate the gentamicin and tobramycin. That's why in resistant organisms we can use this. Wider spectrum of activity. You see same as that of the gentamicin. It is basically a reserve drug for hospital acquired gram-negative bacillary infections and also multi-drug resistant tuberculosis. So, different multi-drug resistant tuberculosis, different hospital acquired severe infections, we can use the amikacin. Here the chance of the toxicity is somewhat lesser. Sisomycin is identical to the gentamicin, equal to toxicities and susceptible to the aminoglycoside inactivating enzymes, more potent on the Pseudomonas and beta hemolytic streptococci. Okay. Netlimycin is another semi-synthetic derivative of the sisomycin. More or it is also resistant to many enzymes that activates gentamicin. So, these newer agents are mainly used in different resistant organisms. Lowest toxicity, more active against the Klebsiella, Enterobacter, but it is less active against the Pseudomonas. Pharmacokinetics use adverse effects are more or less similar, but it is less toxic. Neomycin. Neomycin is wide spectrum, active against the gram-negative bacilli and some gram-positive cocci and obtained from the Streptomyces fradii. Pseudomonas and Streptopygenes are not sensitive, but it is too toxic for parenteral use. That's why mainly used. So, neomycin topical use is there. It is used topically in skin, eye and external ear infections. So, neomycin ear drop is present. neomycin ointment is present, neomycin eye drop is present. So we can use this. Apart from this, it can be used in preparation of bowel before surgery, and you know in the gastrointestinal system that neomycin is used in the hepatic coma because it suppresses the ammonia producing bacteria. So it suppresses ammonia forming coliforms that prevents the hepatic encephalopathy. So why neomycin is used? Neomycin is an aminoglycoside antibiotic, but when it is used in case of the hepatic encephalopathy, it decreases the chances of the hepatic encephalopathy because it suppresses the ammonia production from the coliforms. Okay. So bladder irrigation can also be done with polymyxin B if there is some infection. So these are the neomycin is mainly used in these cases. Phragmicetin is obtained from the Streptomyces lavanduli. It is similar to the neomycin. Phragmicetin is very common as it is used in different types of the skin infections. Used topically on the eye, skin or ear also. So you know about the name soframycin. So this is a phragmicetin. Paromomycin is another which is more or less similar to the neomycin. It has pronounced activity against different protozoal organisms. So when you have read about the anti-protozoal drugs, you have also read about the paromomycin. So it is also active against the Entamoeba histolytica, Giardia lamblia, Trichomonas vaginalis, Cryptosporidium and Leishmania. So this is the aminoglycoside antibiotic, but they have some anti-protozoal action also. So basically these are used mainly in intestinal infections, treatment of the hepatic encephalopathy. Apart from the neomycin, we can also use the paromomycin. Treatment of the MBBS, paromomycin is used, and parenterally it is used in visceral leishmaniasis. So this is the aminoglycoside antibiotic that is also used in killing of the different types of the protozoa. Different protozoal infections, paromomycin is also used. So aminoglycoside use in a nutshell, we can see it is frequently used in combination with a cell active agents. That is usually it is used combination of some glycopeptides or combination with some beta lactams, so that it can cover all the gram positive as well as the different types of the gram negative organisms. So to ultimately when we are combining this, that expand the empiric spectrum of the activity of the antimicrobial regime, provide synergistic bacterial killing, prevent the emergence of the resistance, and combination therapy is also used in healthcare associated pneumonia, sepsis, multi-drug resistant gram negative infections of the Pseudomonas, Enterobacter, Serratia, etc. And use of aminoglycosides to achieve synergistic bacterial cleaning is also done in case of the endocarditis also. So what happens, we usually do not use the aminoglycoside singly. So usually we use in combination with some cell active agents like some beta lactams or with some glycopeptides, like can be used with combination with vancomycin, combination with some piperacillin tazobactam like this, so that there will be more broad spectrum of actions, because in these serious infections not only the gram negative organisms, some gram positive organisms are also active. UTI, urinary tract infections, particularly in serious urinary tract infections, because they achieve a high concentrations within this strains of the E. coli, different types of the E. coli, Serratia are ultimately leads to the different resistant urinary tract infections. A single intramuscular dose of the gentamicin can be used, or 10 to 14 day course of the gentamicin and tobramycin is an alternative for pyelonephritis. So when there is severe infections in the nephrons also, this pyelonephritis, UTI, we can use this. Pneumonia very commonly used, mostly the hospital acquired pneumonia, the patient is already admitted, patient is under respirator or ventilator, serious infections, gram negative infections, also some gram positive infections, we usually use the combinations. So it is mainly used in streptopneumonia, which are common causes of the community acquired pneumonia, and different other hospital acquired pneumonia in combination with the beta lactam antibiotic. It is now recommended as the standard empiric therapy to increase the likelihood that ultimately the patient can be cured. Meningitis, usually the third generation cephalosporins are used, the blood-brain barrier crossing is limited, but we can use the combination of this because some gram negative organisms can also be sensitive to this. Peritonitis can happen as well as the bacterial endocarditis. In both of these cases, we can use the aminoglycosides. Details is not required, just remember the indications. Penicillin and gentamicin is usually effective as a short course, usually 2 weeks therapy. We are using some beta lactam plus aminoglycoside. Combination is given for the 2 weeks therapy. The administration of the gentamicin may be given as a consolidated once daily dosing. In enterococcal endocarditis, concomitant combination of the ampicillin and gentamicin in divided doses can be given. Usually, we can use in staphylococcal tricuspid native valve endocarditis or native mitral or aortic valve staphylococcal endocarditis. So, what happens in case of the endocarditis, the treatment is very difficult because when there is infection in the valves, within the heart valves, we have to use the different other antibiotics. In those cases, we have to use the combination of these. Sepsis, septicemia or sepsis, when there is severe blood infections, mostly this happens now due to the some resistant Shigella or Pseudomonas or Salmonella or E. coli infections. So, in these cases, you can see Pseudomonas aeruginosa is a potential pathogen. Again, we have to use a combination of some beta-lactam antibiotics, very high extended spectrum beta-lactam antibiotics plus aminoglycosides. Okay. Tularemia. So, these are some uncommon infections, but that can happen. Streptomycin or gentamicin is the drug of choice for the treatment of the tularemia. Okay. Plague. Usually a 10-day treatment of the streptomycin or gentamicin is recommended for severe forms of the plague. So, there may be some times when there will be plague epidemic. So, tularemia epidemic or endemicity in some areas, some pockets. So, in those cases, we have to use the aminoglycosides. Some mycobacterium infections, mycobacterium tuberculosis, already we have seen streptomycin, kanamycin, amikacin, these can be used as a part of the treatment of the mycobacterium tuberculosis or TB. Cystic fibrosis. Cystic fibrosis is a disease that can happen due to the mutation of the CFTR protein. So, CFTR is a chloride channel. So, when this cystic fibrosis happens, there is more chances of the severe respiratory infections times and again. So, in these cases, this happens due to the Pseudomonas species and we have to use the aminoglycoside antibiotics. Topical administration, already we have seen, usually we can use neomycin topical administration or paromomycin or framicetin, we can use this topically. In different types of the skin infections, soft tissue infections, mainly in case of the burns or if there is some infections due to some pathogens. So, this is all about the aminoglycoside antibiotics. So, within the aminoglycosides, you have to remember what are the aminoglycoside antibiotics. So, names of the aminoglycoside, difference between the MOICIN and MICIN. Next is what is the common properties of the aminoglycoside antibiotics, very common questions. Next is within the common properties, it will also come about the mechanism of actions, how it acts, very common, how the protein synthesis is blocked, 3 areas, and then comes the most common, what are the adverse drug reactions of the aminoglycosides. This ototoxicity, how it happens, nephrotoxicity and some other agents. Okay. So, this is all about the aminoglycosides. Thank you.